special instruments. We are not going inside with the finger and make a ligature. Now we are identifying the laryngeal nerve important structure like in the open procedure. And what is important? It is important to follow the whole route of the nerve and to be sure that it is the nerve as in the open procedure. No exceptions. And we follow the nerve until the entering to the larynx to be sure, as we do during the open surgery. It is all possible to do with some skills. It isn't possible at the beginning. It is normal. The time at the beginning is longer than with the open procedure. Also, it is normal, but during the cases, you improve your skills, and it isn't so difficult as it is. It looks at the first moment, and just to see how it looks, we identify the laryngeal nerve. We follow the nerve in all route, and after that we can. Here is the nerve. Yes, we follow, and as in the open procedure. Thank you for the video. We can stop the video. Thank you. But what is advantage? I think all of you wants to know. I think. And according to my experience, personal experience, now we have almost 50 cases during the 1.5 years. It is now we are doing in shorter time than normal open procedure. It is less postoperative pain for the patients. It is without suction. Also, and it is a shorter time for the patients in the hospital. And also, it is important that our complications are not are the same. We can say they are not increasing in the complication. In this case, we had only 3 transition temporary paralysis, and also it is normal also for open procedure, and we didn't find any disadvantages, especially because we last half year we started with new devices which are reusable, and it isn't so expensive like the harmonica and the other not reusable. Thank you.
Any comments from the panel?
So any size of the thyroid would be operated on with that technique?
Yes, of course. Yeah, we have a 2 centimeter incision, and it is one of the limitation. You can take out. It depends of the consistency of the nodule. If you have a partly cystic nodule, it can be more than 3 centimeters, but our limit is 3 centimeter nodule. In the case of the cancer, when we have preoperatively cytologically diagnosed the cancer, now we are doing only nodules under the 1.5 centimeter.
And what about neck dissection? And when it is a cancer, Professor Shah didn't address also the problem of the neck dissection. In this technique, do you realize recurrent neck dissection or not? And what are the indication of neck dissection generally? Thank you.
In general, as I mentioned, we do not propose elective dissection of the neck. During the course of thyroidectomy, if you encounter grossly enlarged lymph nodes in the central compartment of the neck, you would take out the largest lymph node sent for frozen section. And I strongly urge that you do that. Many times lymph nodes will be enlarged from Hashimoto's thyroiditis, in which case you will wind up doing an unnecessary central compartment node dissection. So confirm the diagnosis by frozen section. That should be very easy for the pathologist to tell you. If you confirm central compartment nodal metastasis, then clear out the central compartment on both sides, because you don't want to come to the central compartment again. Every repeat operation in the central compartment is hazardous to the blood supply to the parathyroids. So if you are going to do a central compartment node dissection, document it, do it the first time around. We do not propose lateral neck dissection unless you have grossly enlarged lymph nodes. If you have grossly enlarged lymph nodes, do systematic clearance of levels 2 through 5, 2, 3, 4, 5. Level 1 metastases are exceedingly rare in the initial presentation, unless you got recurrent disease after 2, 3 times. So you can safely spare level 1, and therefore the risk to the marginal branch of the facial nerve and the excision of submandibular gland would not be required.
I would like to comment on that. We have in Scandinavia since 3 years a register of all thyroid operations, benign and malignant. And up to date, I think it's 4,000 registered operations. It's both by general surgeons, ENT surgeons, small hospital and big hospital. And from the data, you can see when you do central resection of the compartment, there is a considerably higher risk for hyperparathyroidism. You can discuss if it should be centralized, this type of operation. The other thing is that we have about 4% post-operative recurrent laryngeal nerve palsy as seen within the first 3 months. And it differs in between centers. The centers, mainly general surgeons who do not regularly inspect the larynx, they have a percentage of 1 to 2%. And in institutions where you actually look down and inspect the vocal cords, it's about 3 to 4%. And I think I would like to discuss a little bit this about the complication rates and how we can keep it low, because I think there has been a debate about minimally invasive surgery that you increase the risk for the laryngeal nerve. And the other thing is what do we do to minimize the risk, and what do we do after we actually have laryngeal nerve palsy?
Now, I think it's very important to have a status of how the vocal folds function preoperatively. And this is an issue in Germany because most thyroidectomies are performed by general surgeons, and to save the money, not to send the patient to the ENT to have a laryngoscopy pre-op, they just say, well, if I listen to the voice and the voice sounds fine, then I can go on, and there should be no policy. But if I can have my first slide, please, then I would like to really mention, this is not for the ENT audience of you, but for the general surgeons. Next slide, please. And click, please. Okay, here. So I think it's very important to notice that there are patients who have a unilateral vocal fold paralysis and you cannot hear it. So there's no way of auditory, perceptual diagnosis by any surgeon. The next point is, if a patient has a unilateral paralysis, so one vocal fold doesn't move, this may change your surgical procedure. So if you know one side is affected, you really want to save the other side. And in some cases, as we heard, you don't want to take the whole thyroid out, but maybe just a lobectomy. And for the general surgeons, I think it's a notion that should once be made that a unilateral paralysis is treated totally different than 2 times a unilateral or a bilateral paralysis. So this is a totally different thing to do for phonosurgical purposes. And the last thing is that, so if it happens once, then there are things that can be done by phonosurgery, by voice therapy. And it's not only the voice that is deteriorated and can be improved, but it's also the swallowing. And so we have some tools in our pocket, how we can help the patient. Thanks for the slide.
Yes. And I would like to ask the panel, if you have a situation where you have sacrificed the nerve on one side, so you're sure that it's out of function, and you've done a total thyroidectomy, and you find when you take out the tube of the patient, there is small breathing difficulties and a hoarse voice. What do you do in that situation?
Very good question. First of all, you should never sacrifice the recurrent laryngeal nerve on one side until you have seen the other side, preserved it, protected it, and you are sure that it is intact. In spite of that, you are absolutely right. Some patients will wake up with bilateral vocal fold dysfunction. As long as you know that the one side is intact, you can avoid the need for a tracheostomy. I would reintubate the patient, put the patient on steroids, and slowly wean him off. And in most patients, you can get away without the need for a tracheostomy. The performance of tracheostomy can be life-saving, but I think it can be avoided if the patient is kept under close surveillance, steroids, humidification, slow weaning. You can get away with that.
Yeah. And maybe in cases where this doesn't help, you can also do a temporary lateralization with a very fine instrument from Georgi Lichtenberger, where you suture the vocal fold outside for a couple of days or weeks and then wait until it comes back. Or you can inject Botox into the lateral muscle so that you have a little bit of a slackening of the vocal folds, and this gives you more air.
Professor Bura?
Yes, I agree. Don't be hurry and make decision and to make a tracheostomy. It can be definitely for the patient. I think in the case when we have one side paralyzes because of surgery before or because of invasion of the tumor, we are more careful with the other side, I can say, and also in some cases we have a problem during the end of the anesthesia. But I think also that we can prolong that period and to see for next 2 days.
I think there's also another thing that should be mentioned on cases where you have a patient where you have an immobile fold. And if you ask the surgeon, he says, I swear to God, I didn't touch the RLN. Nothing happened. I didn't even get near and close to it. So what could have happened? There's this phenomenon of synkinesis, so that the adductors and the abductors are both innervated, which means there is impulses going through the nerve to the muscles, but there's an immobility because you have an isometric contraction. And so you have to solve these problems as well, and you can do that by EMG of the larynx.
Thank you. Before we close this session, I would like to ask the panel one last question. There is a lot of CT scans of the thorax done over the counters. For example, for suspicion of embolism to the lung in otherwise healthy people. Usually they cover the lower part of the neck. So we have an increasing number of CT and MRI scans covering the thyroid. And I asked our radiologists, they see a lot. Usually I don't mention it because they are focused on the lung, so they're very kind to us. But we are facing an increasing problem, what we could call incidentalomas. Small nodules, 8, 10 millimeters, that will be presented to us. We can't palpate them. My question is, what shall we do in a case like this?
If it's a sub-centimeter nodule and does not have any other radiological features suspecting carcinoma